You've got your microphone, Dominic? No. Doug, do we have one more handheld mic? No. Okay. We just have one today. Okay. I'd like to welcome everybody here today. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research at the University of Waterloo, and it is my pleasure to have Dr. David Wiljer here to speak to us today on the Engaged and Empowered Patient, Innovative Paradigms for Health Information Technologies. I was just speaking to David and indicating that this is a very strong interest at the University of Waterloo from many different aspects, from the patient point of view, from the areas that he's delved into in terms of cancer care, home care. The whole idea of a person-oriented record is very, very much one that we want to look at strongly in our research areas. So I'm very interested in his presentation. In learning a little bit about David, I didn't realize that he hails from Kitchener, that his parents and his grandparents moved to Kitchener some years ago, actually operated the barbershop, as my understanding, at the Walper Hotel. I mean, these are all very interesting details to me, and that David's father was a professor at the University of Waterloo in the School of Architecture. So there are many ties back to the University of Waterloo. Maybe we can capture you and bring you here more regularly. So I just want to welcome everybody to be engaged in this seminar. If you would hold your questions to the end, we'd like to capture your questions on this presentation because we are webcasting it. We are also going to record it, so it will be available on our online archive. And the questions are an important part of the presentation, so please hold your questions until we can get a mic to you at the end. So without any further ado, Mahira, if you'll introduce our speaker.
Good afternoon and welcome, everyone. It is my pleasure to introduce our guest speaker today. Dr. David Wiljer is a professor in the Department of Radiation Oncology in the Faculty of Medicine at the University of Toronto. Dr. Wiljer is the Director of Knowledge Management and eHealth Innovation at Princess Margaret Hospital and the Chair of the Canadian Committee for Patient Accessible Health Records. Dr. Wiljer has led various research projects such as research, development, implementation, and assessment of complex informatics initiatives for cancer care, and getting results, a portal providing malignant hematology patients access to elements of their health records. Dr. Wiljer is the recipient of the Minister of Health Innovation Award and recently received the Cancer Patient Education Network Gold Star Award for the contribution in the field of informatics for patient education. Today, Dr. Wiljer will talk about the engaged and empowered patient, innovative paradigms for health information technologies. Welcome.
Thank you. Thank you very much for that warm welcome and that very nice introduction. It's nice for a second-generation Kitchener boy to be allowed to cross over that mythical divide over into Waterloo and come and present. And as it was driving up the 401 this morning, I felt my BlackBerry get more and more excited as I got closer to the mothership, and I was reflecting on something that I read yesterday in Health or the Technology Review about reality mining. I don't know if any of you have heard about reality mining, but it's taking the information that's on your BlackBerry, looking at patterns of speech, looking at GPS coordinates, and trying to figure out individual behaviors and change behaviors. And one of the things they were suggesting was that we could do things like detect depression. So if I'm talking very slowly, it might mean that I'm depressed. And so I was reflecting on what that would mean for BlackBerry and RIM, and they could get into the whole service delivery healthcare environment where, you know, if they detected that I was in need of some sort of support, they could have somebody through their GPS coordinates deliver some antidepressant to me, maybe a large Starbucks, and maybe to all of you too if I get boring, so and wake you all up. So, maybe that's sort of the futuristic look of where we're going in terms of some of the technologies. What I want to talk about today is something that's a little bit more down to earth and maybe a little less invasive, I hope, and talk about some of the work that we're doing at Princess Margaret Hospital. So in the next little while, I'll just talk a little bit about background and the context for what we're doing, a little bit about the new information paradigms that we're exploring, and talk about 3 categories of that paradigm in terms of general health information, experiential health information, and personal health information. So my home base is Princess Margaret. We are a large comprehensive cancer center. As some of you may have heard on the news, we're going to conquer cancer in our lifetime. Not sure whose lifetime, but our lifetime. We see about 10,000 new patients each year. It's a very diverse patient population. We do a lot of complex cases, and we think a lot about how to engage patients in their care and to build sustainable systems. So one of my home departments is oncology education. We actually have 3 divisions. We have the business division of oncology education. We have patient education. We have the informatics division. And I head up the informatics division. And what we do is look at research and development projects and try to bring them from concept into the clinic. So sort of the mandate of our educational informatics department is to support patients with information that they need to meet their educational needs, especially patients with very diverse backgrounds, and to really look at how we deal with this concept of delivering the right information to the right patients at the right time. The other, since I've been at Princess Margaret about 6 years, we started with oncology education. We've also responded to this need for survivorship. So one of the consequences of providing better care and starting to grapple with some of the care issues is that patients are living longer, but they also have a number of issues that they have to deal with. And we run each year the Weekend to End Breast Cancer, which raises about $12 million in a weekend for the Princess Margaret Hospital Foundation. And the Walkers insisted that one of the things that we do is develop a survivorship center. So Pam Catton, who's my director, was chosen to lead the development of the breast cancer survivorship program. We have a beautiful space that's integrated with the breast clinic, and patients can come there for a number of different support programs. One of the things that's grown out of that is look at survivorship research. So a lot of the survivorship research is focused on what we call the late effects of cancer treatment and cancer, looking at some of the psychosocial issues. But all this research has really happened in a sort of segregated fashion. So if you say to a basic scientist, we look at survivorship research, that means something very specific to them. We've tried to take a much more holistic approach, putting the patient at the center and saying, well, what do we need to do in order to provide the types of experiences that responds to the patient's needs? And so my piece of this is really looking at that intersection point of patient education and informatics and all of this. And so one of our challenges, I'm not sure if it's as big a challenge here, but in downtown Toronto, if you want to do anything, the first thing people ask you is, do you have it? Not money, space. And where are you going to put all your people? So as we started to work out this concept of survivorship research, we had no seats for anybody, no space to bring people together. So we put together a Canadian Foundation for Innovation grant. We were successful in securing $3.3 million worth of funds. The hospital provided us space in the Toronto General, and we're in the midst of now building that space. We have our architects, and so you see a little bit of a floor plan there. The interesting thing about this space is that this space up here is for researchers. We're going to have space for 36 researchers. We have a community space down here. We're going to bring survivors in for various interventions and to conduct health sciences research. We have an exercise room for self-management techniques. We're going to have a teaching kitchen, so trying to convince Jamie Oliver to come over and do a little TV show for us. We're going to have our own data center and our engineering lab so that we actually have program development happening within this space. So that hopefully the actual space will be built by October this year, or we lose our funding, so that should be done. And then it should be operational by the spring of 2009. We're really looking at 3 platforms, interventions that work with individuals, groups, and communities. So what's really driving all of this? And a lot of the work that we're looking at is really driven by a new paradigm, and that is, traditionally knowledge has really flown from, you collect the data, it goes to the clinician, and then it's dispersed to the patient. And that whole paradigm is really shifting to having the patient in the center. So we have that knowledge, the patient gets that information, and then in some models actually then provides that to the clinicians. And the clinician role in this paradigm is really shifting to more of an advocate, an advisor, a navigator. And patients are seeking that kind of advice from a number of different avenues, and one of them happens to be the internet. So within this paradigm, really what we see is a shift towards the empowerment. And in some circles, empowerment is seen as maybe a bit of a negative concept, in that, as an idea that we're downloading responsibility onto patients. Really what we're looking at is how do we activate patients, and to do that we see 3 major areas that we have to focus on: the individual patient, the organization, and the community level. So for the individual, it's looking at the psychosocial domain, focusing on self-esteem and self-efficacy as an outcome. For the organization, making sure that we have an organization that's going to be responsive to individuals who are taking control of their health care, making sure that we understand it as an organization that it's our obligation to provide timely information and to increase the feeling of power that the organization has. And then as well engaging the community. So I know that we at Princess Margaret have a bit of a reputation of an ivory tower syndrome, and that we only look introspective, and so that's a challenge for us to move beyond the walls of the hospital and recognize that patients only are actually with us for a short period of time, and how do we reach out and take a community empowerment approach as well. It's also forced us to focus on consumers with chronic conditions, a group that Kevin Leonard has coined the 3C term. We published some work in defining 3C patients. And patients must be on long-term continuous treatment or receiving care from multiple providers for a long period of time. And there's certainly a whole list of those. Perhaps not everybody thinks of cancer as one of those conditions, but certainly as treatments get better, as I said, that's the case. And so how do we respond to patients' long-term effects, both with dealing with the possibility of recurrence of cancer as well as the long-term effects certain treatments cause. So what are the benefits of empowered patients? There's certainly a long list. Just highlight a few. The inclusion of patients as a partner in their care is probably number one. Being fast-tracked if they know how to navigate the system. So not getting bogged down and being sent to the wrong clinics and that sort of thing. Being part of the infrastructure. One of the things that we've heard from our patients is that they want to be involved. They want to help manage certain aspects of their care. And so how do we respond to that, and how do we see them as partners if that's what they choose? And if they don't choose, how do we also have a flexible system that incorporates that as well? Some of the other things that we want to improve are the coordination of care to make sure that patients don't get dropped, so that they are followed continuously and that we have contact with them. To provide them access to their health information, we'll come back to that one. That's a major part of my work. And to get them really involved in decision making. So one of the things we've been thinking about is how to use new technologies. I like this slide that Web 2.0 isn't a thing, it's a state of mind. So that means that I never actually have to define it, which is a good thing. But looking at how we harness these new technologies and create a dynamic and fluid system that we are currently responding to. And really what it's forced us to think about is the role of the web in all of this. Instead of a static place for information, to create this paradigm where we have actually an intervention, that we have information, that we provide an actionable outcome, but more important that we're focused on the end, which is health outcomes. So I, as much as anybody, like the cool factor of technology. I like the gadgets, but you know, but the cool factor isn't enough. We have to be impacting health outcomes and actually showing real value. So interventions, there are a whole list of interventions that people are exploring, from decision support to social support and self-help. There are a number of different paradigms for information, knowledge transfer to from simple concepts all the way to online mini-med schools, which my colleague Dr. Evans is working on. The actionable information can be a whole range, from smoking cessation to exercise, self-reflection, weight control. And then really we can look at a whole host of health outcomes depending on the intervention, from self-management to improved health status. And I just throw up this very busy slide, which my colleague Gunther Eisenbach put together, this map. Some of you might have seen this before. And really what he's trying to do is look at the role of tailored information in all of this. What are the positives and what are the negatives? And in terms of content, really what are the impacts of providing tailored information, and what are the risks of providing too much and too little in this paradigm? So we're continuing to experience this paradigm shift, and I think really where we were a few years ago of looking at tailoring health information and moving from generic information to targeted and personalized information. And what we're proposing is we've actually, especially in the realm of chronic disease, moving that paradigm from the information that's given at a clinical encounter to various layers of, okay, so I have my clinical encounter, then I need some generic information to understand, so what is breast cancer, for example? And then I need that experiential health information. So what do people experience when they have breast cancer, and what can I expect? To, okay, how do I make decisions about my own personal experience? So what is the role of personal health information? So I'm going to just focus on those three areas for the next few minutes. I'll go over general health information fairly quickly, but really it's about gaining information about health and wellness, new drugs and treatments, finding the right information, and evaluating, is this the right information for me? Is it credible? Experiential information is about overcoming that feeling of isolation, beginning to create that network and become a more significant stakeholder in my care. And personal health information is about the desire to play a more significant role in managing my care, giving me the information and the access to that information, whether that be test results or lab work. Really, it's creating that environment of empowerment. So general health information is about finding information. In the cancer world, we have a pretty good idea of the types of information that people are looking for. This graph actually creates a taxonomy of that information from a systematic review done by Rutten and her group. And the yellow bar represents the type of information that people want at diagnosis and treatment, and the green represents whatever greeny color that happens to be, the post-treatment information. And so, at the diagnosis and treatment, it's not surprising that people want cancer-specific information. But at both stages of pre- and post-treatment, look at how much information people want in the treatment-related information. It doesn't stop just because they received that treatment. They need to know more. And again, it's not surprising that post-treatment people need to know about rehabilitation and these sorts of things. So we have a pretty good idea of what kind of treatment or what kind of information people are seeking. In the last 6 years at Princess Margaret, we've developed a number of technologies, websites, virtual tours to respond to this type of information. The yellow shows the operational and the development, and the white shows the what's in general use. Left off at 06, we've obviously continued to do this, but this gives you an idea of the types of technologies that we've developed. I'll just show one here, which is the Caring in Community. A few years ago, we developed this palliative care website geared for patients, their caregivers, and their healthcare professionals to really help to sort through some of the problems. So we had a very problem-driven approach here as information seeking. They could answer a series of questions, for example, about communicating with their pain, and then they would be given tools to track that and to communicate better with their healthcare providers. This is still very much in the realm of the general health information. There are millions of examples of this out there. But this is just one of the sites that we've developed to respond to our patients. So I'm going to move to experiential information. And so what I mean by this is that support network. And the solar system type image that you see over here, I actually found recently. This is some work done by Matthew Hurst from MIT, looking at novel ways of mapping social networks. So each one of those nodes is a blog, and they color code the different types of blogs. And so this is just one example, but he's got a whole series of ones that are political blogs versus technology blogs and the types of interactions. So we are in this very odd world of connectivity, and how do we harness that for healthcare? And there certainly isn't any shortage of sites that you can go to if you want social support. But what's really happened in this space over the last few years is that the social networking has become actually a catalyst for further isolation of organizations. So organizations and healthcare providers are over here saying, well, we'll just send the patients over to the Yahoo groups or whatever space that they choose, and they can interact with one another. But we don't really want to have anything to do with that, because that's kind of scary. Like, we're going to let people talk to each other, and what if they say things about us and all of those issues? And so we don't really want to be part of that. We actually received some funding from an organization called the Quilt, which is in Stratford. And the Quilt actually, they are a group of people who make quilts, and they auction them off, and they support Wellspring, and they support one of our initiatives. And they're about social networking, and so they like the idea of us spending some time exploring this space. And so what we've tried to do is we've created a platform, Caring Voices, and what I like to say is we're trying to turn the organization inside out. So we're letting people in by providing a presence on the outside. And so we are not only creating a community of breast cancer survivors at this point, but our healthcare providers are out there interacting with them. So I'll show you a little bit of that. What we wanted to do, this wasn't meant to be an information site. You'll find some links to other sites, but really we have a few educational resources to help discussion. We have regular monthly programming. So right now in the breast cancer sphere alone, we're up to 10 events per month. These are scheduled events. We have 3 types of events, which I'll talk about in a minute. We have online chats. We have forums, which we moderate. We've created a friend matching, sort of the lava life of social networking for breast cancer patients, where they can find somebody who's like them to get the support they need. We don't advocate dating or anything like that. So this is what the platform looks like. We actually had a large donation from a Toronto company called Click Communications who helped us build this platform. As I said, we have the resource library, we have events, chats and forums, and the people match. You can log on with your profile. The people match has actually gone through a couple of iterations, and we've been trying to figure out what are the touch points that people want to relate to others on. So obviously type of disease, their age, where they are in their own family, whether they have children or those sorts of things, are things that we're matching. And in the second iteration, which we're about to launch, and I'll show you, we're trying to refine that a little bit more and get a deeper understanding of how to actually do that matching in a way that gets the most benefit for patients. Some educational resources that we provide. There's a monthly calendar of events. So as I said, there are 3 types of events that we run. We have volunteers who we've trained, given them psychosocial support. They run their own events. We check in to provide some support for them, but they actually have groups of people that they work with. And this has actually been great for our volunteers because a lot of them work, and this is an avenue that they can do from their desk at lunchtime or from home in the evening. It gives them the sense of giving back, but they don't have to come into the hospital, and frankly, some of them don't want to come back to the hospital. It wasn't really a positive experience for them, what they had to go through, so they like to be able to do this from home. The second type is what we call talking sticks, and it's really sort of a drop-in. You can meet our social workers, and they will do general drop-in. And then we have clinical corners where various physicians and clinicians will talk about issues like chemotherapy side effects, radiation side effects. They'll talk about diet, nutrition, and those sorts of issues. This is our chat lobby. It's sort of a rudimentary chat site, but it doesn't require any plugins, so we can access it anywhere, as well as we get a transcript that people can see. And so we're in the process now of rolling this out. In the next month or so, we're going to launch our general cancer site. We also have agreements with the kidney cancer group at PMH and the National Kidney Advocacy Group. They're going to build a sub-site as well, and we're in discussion with the Canadian Partnership Against Cancer to roll this out as a platform that will be available. The idea was always that this was to be a national platform. That's why the branding is around Caring Voices. It's not around Princess Margaret. The challenge of getting people involved from across the country is something that we're working on, and certainly the help of the Canadian Partnership Against Cancer will help us do that. So I mentioned the new profile. This shows you just a little bit that we're working on that and that we're expanding our profile. So one of the things we've done is taken this platform and we're conducting various research studies. So one of the problems we have with our breast cancer survivors is managing their lymphedema. So for those of you who don't know, lymphedema is the condition that happens, the swelling in the arm or the leg when, well, we don't actually know exactly why it happens, but it seems to be related to the removal of lymph nodes and various treatments. And so this can be a debilitating thing for patients. They can end up with arms that extend out to there and basically aren't usable. So we teach them a whole series of techniques, but then they leave the hospital and they don't necessarily have that connection. So and they don't have the support on how to do that. So we got funding from the Canadian Breast Cancer Research Alliance to run a study using our Caring Voices platform with these patients. And really what we're doing is adding some educational interventions. We set up times that the patients can meet with us in small groups after their standard of care. They're participating on 4 online educational sessions, and we're looking at a number of different outcomes. So this is our protocol. We are recruiting them into the study. now this has actually been a challenging study, so we started off with the protocol said that the patients had to have a lymph volume of greater than 15%. But our clinics have changed a lot since we initiated them. We've removed some of these barriers. So now any patient who has lymphedema can come into our study. They get their standard of care. We administer the DASH and FACET score. So DASH is a arm mobility scale. FACET is a quality of life scale. Those are the two main endpoints that we're looking at, as well as are we reducing the swelling. We then have them go through the lymph line enrollment. They have their 4 online educational sessions. They have a follow-up appointment where we, again, measure their fluid volumes, and we see whether or not that this intervention has helped them adhere to their care plan. So are they actually doing what they set out to do in the first place? And then we're going to conduct a series of focus groups. So we're actually coming up to the end of our 2-year funding on this project, and we're actually just starting working with the patients. It was going to be one of those really easy projects, no problem. We had it all figured out. It really didn't work out that way. There was just an enormous amount of challenges. We had turnover in the clinic staff. Our entire demographic in the clinic changed as we had seen our initial group of patients who had severe problems, and now we're seeing patients who have less severe problems. So we've had to redesign the study 3 or 4 times, and I now think have 12 amendments for the study sitting on my desk. So we're now actively recruiting and hope to report the results in the near future. So that's some of the work that we're doing in the experiential realm. I'll just move quickly to the personal health information realm. How do we actually give patients access to the results? Seems like a pretty simple thing to do, right? Kevin and I wrote this paper around who will demand access to their personal health record, and looking at the demand that the 3C patients will have for accessing their health information. But this doesn't really come from us. We know that patients want to have access. 69% of patients would like access to their online charts. 80% would like personalized, relevant information. 83% want their lab results. 84% would like electronic alerts. Surprise, surprise, physicians weren't that excited about doing this. It's shocking. But what is really shocking in all of this is that this data is from 2000, so 8 years ago. And where are we really? I mean, the state is, especially in Canada, we have a few pilot projects that we're doing, some work that's rolling out, but we had 69% patients 8 years ago who wanted to do this, and we really haven't responded to that need. And so what are the barriers to that? Well, we are in the unique position in Canada where we actually have the right to access patient information ingrained in common law. That was solidified by a Supreme Court ruling in 1992, as well as we have legislation that not only says that patients have right to access this information, but we have an obligation to provide it in a format that makes it easy for them to understand. And I would suggest that as part of the healthcare system, we're not doing a good job at this. And it's something that we've kind of shied away from and have been very concerned about. There's been a lot of talk about using personal health records. Jamia published this white paper on whether or not we should be doing patient portals. There were a lot of potential benefits that were identified in this paper by Tang, including the fact that we would have a repository of data, we would have decision support tools, and tools for chronic disease management. The big problem is that the number one barrier is if you don't have all that information in one spot, how are you going to give it to people? So how do we make sure that the electronic health record is viable? And that's got to be a cornerstone of doing all of this. Luckily, the work of Canada Health InfoWay is helping in this area. We did a survey a couple of years ago, actually a year and a half ago now, and we asked hospitals across Canada, do you have an EHR? So 54.2% said yes. But we said, so is that the only place? And you're storing that data, and well, you might be surprised. They said, well, actually 97% said, no, we got it in various places. So we still are battling this issue of not having all of the information in a couple of places that we can disseminate that easily. I heard a talk from Canada Health Infoway recently where they were saying that actually Canada is at about 22% of saturation in terms of access to electronic health records. Oh, so is that good or bad? Well, Spain is actually at 92%. So why can Spain do it and we can't? It's a good question. So one of the things that our committee for patient accessible health records has been doing is trying to create a map. What are the issues that we're going to have to deal with? The patient access issues. What are the privacy issues? What are the education issues? So as the legislation says, it's not just enough to provide patients access to that information. We have a responsibility to make sure they can understand it. And the strategies for change. So we have to change practice. People aren't used to patients walking in with their pathology report before the physician has even seen it and say, Doc, what does this mean? And they're saying, oh, well, I haven't looked at that yet. It's a little uncomfortable for people. So how do we deal with that? So about 3 years ago, we started a pilot project of giving hematology patients access to their electronic health record. This is a patient population that comes in at certain points of their care, sometimes 3, 4, 5 times a week. Sometimes they're there for 5 to 8 hours. They spend a lot of time waiting for various things, and one of them is access to their test results. So they have to stick around to find out whether or not they need a transfusion, and if so, they can wait for 4 hours. Sometimes they wait, and by the time they find out whether or not they can get it, it's too late to administer the blood products, so they have to go home and come back the next day. So we looked at how we could actually improve that process by providing them access to their health information. We created a down and dirty prototype, and patients could log in. There were no bells and whistles. It was straight access and with a little bit of actionable information. But patients loved this. This, for them, was a great tool. We gave them some information, what happens if your blood counts have gone up or down, and some videos. This is Dr. Minden, one of our hematology physicians, who did a video for the various scenarios. So we were at the rough stages of creating information around the algorithms, but built into this prototype weren't actually the algorithms to deliver that information. Patients had to search it out. So we had 27 patients involved in our pilot. The 36% accessed the site 2 to 5 times, 36% accessed it 6 to 10 times. They had access for 2 months. The low response rate is in part due to the fact that this is a very sick patient population. We had several patients who died while they were actually on the study. So it's a difficult population to work with, but they also had big impact on their lives if they didn't have to come into the hospital. So 81% reported that it made it easier for them to understand the results and what to do, and 72% liked it. So we did some interviews with those who could come in, and then we got similar feedback, but we had one patient who came in with this Excel spreadsheet that was the mother of all Excel spreadsheets. He had all his data in there, all his test results. He said, your application is useless to me. I have all of this data. I can trend it this way and that way. So it just shows that certain patients are always going to be ahead of us, but there is that need in this patient population. It was a big team. It was a zero budget project. We had to beg and borrow and steal. But the ministry was kind enough to give us an award, which got the attention of the entire organization, and we decided maybe we should do something about this. So we started creating a larger patient portal, and what we've got is now InfoWell. We actually used the same technology that Claudette DeLeonardo pioneered here in Kitchener-Waterloo and built it out for our own purposes. And this portal is now being used for breast cancer patients. We're running a pilot study. is being used for diabetes patients, as well as there is a joint LIN initiative with Canada Health InfoWay, which I'm sure many of you are aware of, looking at chronic kidney disease. So the portal does a number of different things. It allows us to do some messaging. It has a My Health section. We've focused a lot on the patient education aspect, providing a library. We have a whole library of various pamphlets, and so patients can access those pamphlets here, as well as support, access to support, including Caring Voices, and the calendar tool. So we did the My Results tool over again, creating algorithms for information. This was fairly rudimentary, figuring out what information to give patients based on whether their values have gone up and down. It's a very complex problem, and certainly we just started to scrape the surface of this, but this is one of the areas that we're looking at in terms of our research is how do you start to build in more complex profiles if patients are on chemotherapy and their blood counts are going to be down. Maybe their values definitely aren't going to be normal in comparison to the general population. So how do we start to grapple with some of these issues? We created an agreement with Claudette and Grand River to use some of their protocol information so that we can give information about our chemotherapy protocols to our patients. And that memorandum that we had between Grand River and UHN is in itself an innovation. The fact that we're actually sharing content. Really what's happening is we're in a situation where every center is creating the same information. And how many pamphlets do we need on what is breast cancer? Well, hopefully we only need one or two. So getting that momentum of actually sharing the content is very important. So we are in the middle of conducting a breast cancer study to look at how we can use this portal to improve care. There were two main outcomes that we focused on for this study. One was anxiety, and the reason for focusing on anxiety was twofold. First of all, the physicians were telling us that they thought this tool was going to increase anxiety. But our hypothesis was that it was actually going to reduce the anxiety that patients were experiencing. So that was a very important outcome for us to focus on. And the second one was self-efficacy. So do they feel more empowered to participate in their care? This is our protocol for this study. So they come into our survivorship center. We consent them into the study. If we enroll them into the platform, and this was actually a lesson learned for us, that it wasn't enough to consent them and give them a URL. We actually had to enroll them right there in the clinic. Otherwise, it wouldn't be real for them, and they needed a little bit of support to find their way through the portal. They then had to do their pre-test, which has a demographic questionnaire, an impact assessment tool, the state trait anxiety inventory, which we use for anxiety, and the Stanford self-efficacy scale were administered. They then used the portal for 6 weeks. They had support through our group and through the Systems Information Management group at SIMS. We're collecting usage data. I'll come back to that support piece in a minute. And then the post-test was, again, the impact assessment, the 2 scales, as well as a fourth one, which is our heuristic for usability. We've also conducted interviews. We've conducted 16 patient interviews and 8 staff interviews. So I don't have all of the results for you. We just actually closed data collection on the 1st of March. So we're in the process of analyzing that. I have a couple of things to share. So we had 250 patients who actually consented and are participating in the portal. We consented 320. So there was a group there that was dropping off that we weren't actually capturing. We had 120 who have completed all of our instruments, and as I said, we have 16 who have participated in interviews. Patients really like this initiative. We're hearing in the interviews, I heard things like, I just like to look at my results. Sometimes when I'm feeling down, I'll just pull up my pathology report and look at it. Makes me feel better. It doesn't matter to me that I don't understand everything there. I'd like to be prepared. I'd like to be able to do the research before I go into my appointment, and I'd rather be prepared. So this doesn't represent all patients, obviously. There are patients who are going to face real barriers with this, but patients then form their own networks. One of the big issues that we came across is around support. And so for the purposes of the study, we basically set up a triage. So one of our research assistants became that contact person. We had quite a few, we had about 150 calls altogether. The issues that we had were mostly technical. We had 2 clinical questions, which was an important finding for us because, again, the clinicians were saying that patients were going to be phoning in, and this was going to be a big burden for them. And we had 1 clinical education question that we dealt with. The clinical issues were around anxiety, and surprisingly enough, it was anxiety provoked by not being able to access their record. So I thought I was going to get access. You said it would be available in 2 or 3 weeks. I had my test a month ago, and I have no results, and I'm anxious about it. So those were the sorts of things we're dealing with. In terms of the technical support, we had issues around registration, accessing the site, doing password. We had a complex activation key for the results and that sort of thing. So again, a large team, and we've been fortunate to receive an award. SIMS received an award for the work they're doing here from McKesson, and as I said, we're moving forward in a number of different fronts. So just to wrap up, I mean, I think this new paradigm is really a challenge for us in the healthcare field. How do we deal with it? What are the multiple layers that we have to address, from the social networking to the providing the basic information? Patients are becoming a real conduit in the transfer of information. We have different types of information that we need to provide and think about information in new ways. We really, at the cornerstone, I believe in all of this, is to give patients access to their health record. So thank you very much for inviting me.
So we have a chance to ask questions and make comments on some of the work you've done or parts you're interested in. We'll start.
Fascinating stuff. I enjoyed your talk very much.
Thank you very much.
A couple of questions. It seems that some of your data, statistics, whatever you want to, words you want to use here, are somewhat self-selective in the sense that the kind, you're getting these very high rates, but those are probably the early adopters or something like that, those kind of people.
Yep.
And the other one, do you have any feeling for compliance? Because with chronic disease, it's a lifetime thing, and you have to, maintain I'll call it a healthy lifestyle, and a lot of words go around that. But, are people sticking with what you're doing, or do you really have a chance to measure that? Because, it's pretty new stuff. So.
Right. So I'll deal with the first question first, in terms of the bias of the data. And yes, I'd acknowledge that there is a bias there. For a couple of reasons. One is that patients who have the technology are the ones who are being recruited into these studies. So you have a certain group there. We're also doing it in clinics where there's a need. So, for example, with the hematology clinic, you have patients who actually need access to that information, and it improves their life. So you've got a skew there. It's not just a general population. So definitely it remains to be seen what exactly the impact is going to be. But generally, if you think about it, if I ask people, well, if your test results were available and you wanted to be able to access them, is that something you do? And most people, I would say 95% of the people I talk to say yes. And that's really the foundation of that, is that people want access to that information. And so there's a sort of transparency issue there that I think we need to deal with as we move forward. So yes, the data is a little bit skewed, but I think that we will see positive results as we move forward. Adherence or compliance, or whatever you like to call it, is a really important issue. And so the hypothesis of all of this is if we can get them more involved in their care, we will have better health outcomes. We don't have a really strong data to support that yet. There are a couple of randomized control studies that suggest that we're heading in the right direction. But that's really where we need to focus. And we're kind of caught in that awkward situation where we have this hypothesis, but we need to build good interventions in order to test them. So that's going to be, I hope, some of the exciting work that we're going to do in our Elixir facility over the next couple of years. Thank you for your question.
David, I enjoyed your talk very much.
Thanks, Laura.
I wonder, you mentioned several times the idea of comprehension of the information,
Yeah.
whether it's general or whether it's personal health information. Have you any thoughts about how you're going to actually assess that? Again, the concept of, thrombocytopenia is difficult for even an expert to understand, let alone somebody who's looking at their personal health record.
Yeah, and it's one of the areas that we definitely need to focus on in terms of our research. Chris Ann and I have been looking at how you can build some tailoring mechanisms for making clinical reports easier to understand. One of the big initiatives that we've undertaken in our survivorship clinic is to go to synoptic reporting for disseminating information. So what's the value of that? Well, what we've been able to do is collect a common data set and produce multiple reports. So reports that are comprehensible to physicians, those that are comprehensible to patients, and we can even take that to other levels of making various levels of information available. So those for people who have low literacy, higher literacy, visual learners. But until we have a common data set to do this on, it's really hard to deal with that issue. Now, we have a large patient education department, as you know, that does a lot of work around plain language. And so we have some principles in working towards grade 6 information and the general health information. That's a big challenge, and we don't always get there, but that's certainly one of our goals. But there are a number of different strategies we're going to have to take here. Language is a huge issue. In terms of our patient population, we have hundreds of different ethnicities that we have to serve, and we have 8 major languages, and English is becoming a smaller and smaller percentage of our patients. So how do we deal with that? Certainly being able to tailor information through these kinds of systems and give information in various languages will be helpful as well. That's a huge problem, and it's an enormous challenge.
Very exciting talk.
Thank you.
One of the things you alluded to is building something, excuse me, that's coherent and efficiently done. So you're working with Grand River, terrific, and the Canadian Partnership Against Cancer provides an opportunity, I guess, to link with other groups. But I was sitting here thinking what you're trying to do is create an environment that supports patients. Other groups are working on similar things. What's going on to create coherence among people who are working on these kinds of things in Canada?
That's an excellent question, and something I worry a lot about, because there's been a lot of great work done by Canada Health Infoway on the electronic health record, but we still have this very fragmented landscape, and I think Ontario is the worst. We're extremely, in terms of our fragmentation. And so we have an opportunity here, I think, to tackle this problem early on. Canada Health Infoway is actually commissioned a report to look at whether or not they should get into this space. One of the big problems is that the heavy hitters are now moving into this space. So Google and Microsoft are coming in, and that makes people a little bit reticent to invest, because if Google and Microsoft are going to come in with the solutions, why should we do that? But there's also an opportunity to partner there. I've been, for the last 3 or 4 years, chairing this National Committee for Patient Accessible Health Records. We have come up with a consensus document in terms of some recommendations on how to move forward. And that's available now through Canada Health Infoway. And we've also been in discussion with Coach to create a set of guidelines. But what we need is some leadership, and we need provincial leadership around this issue. We need some federal leadership, and I think that may happen. and we're certainly knocking on some doors to make that happen. We need as many voices as possible. The other thing we need to do is engage patients in this whole thing and get them to demand the fact that it's not acceptable that if you're being treated in Toronto and you have a test done at Mount Sinai and you walk over to Princess Margaret through the tunnel and they're connected, you can't get that information necessarily. I mean, patients are frustrated by that. We're working towards that, we're improving it, and it's a big challenge. But we need to harness the popular voice on this too.
Actually, it's for me. Sorry.
Are there actually people out there in the web?
David, my understanding is that websites with medical information are classified as medical devices and need certification. I'm not right up on the rules myself, but I'm curious to know if you're heading that direction or certified already. The reason I ask is that I believe it impacts your software development in a huge way. Like, it's tremendous overhead. You make one line of code change, and I'll exaggerate, you fill a binder with description as to why you made that change. I guess I'm curious to know if you're doing that, heading that direction. And second, I don't know if the certification affects the actual content, so that if you change a page, for example, does that have to go through the certification process as well? Do you know?
So I'm not aware of that content has to go through that revision. We have, as an organization, when we post content, we worry about the liability issues, certainly. And so all content has to go through an extensive review process. And so that content creation process is quite labor intensive. In terms of the application, I think we're still in a lot of the spaces that we're talking about in the early stages. So we need some leadership around the standards creation. And they haven't, as I understand it, they haven't yet been classified as devices. And one of the ways we get around that is we don't provide medical advice on most of our platforms. We provide educational support. But as we start to deliver health information, that's going to change, and so we're going to have to address all of those issues. But it's a bit of a vacuum right now, and we're going to need some help. And I'm hopeful that Canada Health InfoWay will jump into this space and start to work through that. But we'll see.
I worked with Dr. Siegel in cancer rehab in Ottawa. And I was just wondering, can this platform help increase accessibility with exercise rehab or things like, say, art therapy or support?
Yeah, so the InfoWell portal, one of the things that they've done for the chronic kidney disease group is to build in plans for things like diet, nutrition, and for exercise. So to provide some tools that not only allow you to set out a plan, but also give you some reminders and some guidance and help you through. So we're heading in that direction, but certainly we haven't got very far yet.
I just want to make a comment about a couple of things. Canada Health InfoWay is already in this space. I guess they got their toes in it anyway because they have funded at least 2 portal developments with patient information, and at least some of them have even a type of patient record being formed on that. I guess what amazes me, and you alluded this in one of your research projects, that it took more time than you expected to actually get to the completion of that project. Both of these projects that Canada Health InfoWay have funded are underneath the Innovation and Adoption Program, which by the very nature are 18 months in length. And I find it rather amazing that this innovation is going to be defined within 18 months, one way or the other. So I know those projects are struggling with that timeline, and I hope that Canada Health InfoWay will sort of review that. I don't know if you've got anything to comment about that.
Yeah, I certainly didn't want to imply that they're not interested in not supporting projects. I think one of the things that Canada Health InfoWay is struggling with is this patient access to their own health records. Should that be part of their core business? And they're interested in fostering innovation and so on, but in terms of their core mandate of implementing electronic health records and having access to that, what role should they play in that? So that's all I meant to allude to. They've certainly been very supportive of a lot of our work. But it takes time, as you say. These projects are very labor intensive. Claudine and I often joke that we never know what is going to be the next issue that's going to jump out at you, who's going to be the next person who says, well, what about X or what about Y, and how are you going to deal with this issue? So we're kind of pioneering an area here, and it doesn't happen overnight.
Right. And the issues that I see them struggling with, it's not the technology of the portal that's causing delays. It's all of the human factors. It's all of the interactions and the protocols that you have to think through. As you indicated, staff may not be constant through all of this. Engaging in the patient in this takes time. So I find the timelines rather I guess unrealistic. So I hope we can be still innovative in 18 months.
Well, I think the issue there is that the concept of these sort of rigidly managed projects is rather than true innovation. That Infoway has admitted, at least in discussions with me, that it's a problem. That that you don't have the same kind of flexibility that you have in a true research program. And what happens is things are getting raced through. So we're seeing important issues being sidelined and not being addressed. One issue I wanted to ask you about is the comment that was made about accreditation or certification of portals is certainly an important topic, and we've been dealing with some law firms related to that. But if you have a portal, it expresses a mode of care. In other words, in the portal, the content, the interactive approaches, the protocols are an embodiment of a method of care. On the other hand, there's another method of care potentially, which is what happens in the clinic. And there seems to me, and I know in certain instances, there are significant misalignments between those two. What are you doing so that you get that alignment? In other words, so that the people in the clinic back this up. And I'll add to the question and begin to communicate with the patients, because as they find things out from this connection mechanism, that needs to feed into the clinic to the next visit if the patient comes in. What's happening with regard to that?
So one of the things that we've grappled with from the beginning is who should be driving these projects. And we've been very fortunate that it's been the clinicians who have actually, on both projects, been the drivers, and they're at the table. So with the hematology project, that was actually, I was one of the leaders, but there were 4 nurses who were at the table designing that initiative. If you don't have them engaged and they're not doing, if they're not doing the same things online as they are in the clinic, it's hard for them, it's hard for the patients, and they recognize that. So if you don't have the clinicians on side right from the beginning, that's only one of the problems you're going to have. And it takes time, and you need to find a couple of champions. So that's really what we've done, is we've, from our side, tried to find a couple of clinicians who actually believe in this. We're very fortunate that we have a leadership that believes in this. Pilot it with them, and then create that interaction, and to design from the clinic flow perspective rather than to design from the technology perspective.
So you mentioned there is somewhere back in your slides, some resistance at the other end to this. I've seen several kinds of resistance. One is patients come in hyper-prepared and the physicians don't like that. But the other part of it is that you create communications capabilities and the physicians don't want to receive them. And yet you're capturing that. So there's a statement in the record, but it's not being brought into the clinic. Have you dealt with that then in your work here, or is that still an outstanding problem?
That's still an outstanding problem. And the whole issue further to that of when patients are inputting data, how do we make sure that clinicians are responding to that if there if there are issues that need to be responded to? We've shied away from dealing with that today. That's something that's on our slate of issues to deal with. But
just give you one example, and it'd be interesting actually interacting with you. We're already working with you through Chris-Ann and the personalization. Is we've discovered in CKD patients, chronic kidney disease patients, that about 40% are depressed. And it's also characteristic of depressed people to be high utilizers of the health system. And one of the goals of the portal is reduction in health system or appropriate use of the health system.
Right.
The problem is that we actually added into the portal a basic assessment of depression. And the question then is, if you know patients are depressed, are you going to deal with that in the clinic? You know, it just becomes an incredible problem. So there's an example where the very use of the technology depends upon interventions. The detection of the need for the intervention occurs in the technology, and you got a major problem in even showing this thing is at all efficacious in that environment.
So I smile because we've been having this discussion in terms of should we use the portal for distress screening, just as what you're talking about. And if you find out your patients are depressed or distressed, what are you going to do about it? And if you can't respond, you've all of a sudden created a huge problem. So there are a couple of initiatives around the province looking at how you deal with distress screening. And I think in Thunder Bay, actually, in the cancer center there, they've done some interesting work. But we're in the middle of grappling with that issue. And how do you triage patients? What are your cutoffs in terms of the distress screening? How do you make sure you follow up with them? You know, are there other mechanisms, referral mechanisms, information mechanisms that we can use to deal with it? And, you know, is it, if you don't want to know, don't ask? Or do we have a responsibility to ask? And that's really the fundamental problem that we're grappling with. If you don't know that it exists, does it still exist?
Okay, good. Well, good.
You alluded to a couple of instances where you've partnered or you've collaborated with other public institutions like Grand River Hospital.
Yep.
Do you have any partnerships in place or any workings with the private sector? I know I saw the McKesson logo up there, I think, at one point, which is, I believe, one of the partners in some of the Grand River work.
Yeah. So my program in particular is funded by donations to the foundation. And so if we want to do projects, we need to find partners. And that is a cornerstone of all the work that we do. So the Caring Voices platform that I showed you, that was an industry platform. They put in a fairly significant donation. We've worked closely with other software developers. We had a product called Oncology Interactive Education Series, which is still being used and is being moved to the web. We partnered with a company to do that. So yeah, we're right in there trying to figure out how we collaborate, how we give benefit back to industry, how we set up relationships that work for us too, because there's some rules around that. And you know, you only need to say industry collaboration once to start to have to grapple with the issue of pharmaceutical sponsorship and involvement. And so certainly there's a whole other can of worms there in terms of should we be taking money from pharmaceutical companies to do these projects. So yeah, we're in there, we're dealing with those issues. We have several successful collaborations, and we need to do that.
Any final comments, Chrisanne or Jose, about your work? Or?
No, actually, David and I have just talked for about an hour before this, so I got to ask all the questions.
Okay, good.
But so I'm trying to do something for
Well, I'll then thank you very much. A very interesting talk, very relevant, and look forward to at least one set of interactions already underway. So thank you very much.
Thank you.
Thank you.